Good afternoon, respected judges and all the dignitaries present here in the room. My name is Dr. Jessica Basumatari, and my paper is on atypical visual fields in atypical retinitis pigmentosa. So it is a case series of 3 cases. I don't have any financial or conflict of interest. To highlight the challenges, the purpose was to highlight the challenges in diagnosing atypical cases of retinitis pigmentosa and the importance of 120-degree visual field analysis in such cases. Coming to introduction, retinitis pigmentosa is a hereditary retinal dystrophy that was first described in 1853. It is characterized by progressive degeneration of rod photoreceptors, though eventually cones are also involved, leading to severe visual impairment. The classical features include a triad of bony spicules-like pigmentation in the mid-peripheral retina, waxy disc pallor, and arteriolar attenuation. Atypical RP may not present with these typical features, making its diagnosis a challenge. Sectoral RP, RP sign pigmento, and retinitis punctata albicans are some of the atypical phenotypes of RP. Visual field loss in RP begins as patchy loss of mid-peripheral and peripheral field, followed by ring scotoma, tunnel vision, and involvement of the central vision at the end stage. Case 1. He was a 52-year-old male coming with the chief complaints of blurring of vision in right eye since 3 months. He had a history of cataract surgery in right eye 3 months back, and on examination, the BCV in the right eye was 618, in the left eye it was 69. PCIOL in the bag was in the right eye, and left eye had NS grade 2 cataract. So this was the 30-2 Humphrey field report. So what we see here is that there is scotoma which appears to be respecting the vertical midline. In RP, the scotomas are usually paracentral, and then ultimately a tunnel vision is remaining in the end stage of the disease. So here in the right eye, it seems like it is respecting the vertical meridian like a binasal field defect. This is the 120-degree supra threshold test full field on the right-hand side. So on ERG, we see that the photopic and scotopic responses are grossly reduced. On OCT, there is a cystoid macular edema in the right eye. FFA shows a petaloid appearance. This patient was then treated with topical carbonic anhydrase inhibitor and NSAIDs. After 6 months, the edema resolved. However, at 1 year follow-up, there was a recurrence of the CME, and the final visual acuity in the right eye was 6/12. The key points here to discuss is whether the CME was due to retinitis pigmentosa or whether it was because of pseudophakic CME. Because of the duration of presentation, the patient presented to us at 3 months, which is the classic duration of presentation in Irvin-Gass syndrome. So in RP, CME can result in drastic reduction in visual acuity. It is seen in 10 to 50% of patients. The pathogenesis of these two conditions are variant. However, the treatment line is similar. Now, what is binasal field defect, even if there is such a thing? Now we know that bitemporal field defect is due to optic chiasmal compression, but what about binasal field defect? There have been some studies reporting that there can be complete binasal hemianopia like the one that I have quoted, and according to them, the pathogenesis is because of a defect in the normal sorting of the ganglion cells that decussate at the optic chiasma. Other causes, ocular causes, could be ischemic optic neuropathy, optic nerve head roots, and glaucoma retinitis sign pigmentosa, like we see in this case. However, mostly binasal field defect is artifactual, and it is due to a defect in the testing procedure. Case number 2, 44-year-old male with nil systemic features. Chief complaints is difficulty in near work since 1 year. The fundus shows scattered bony spicules in the periphery. And in the left eye, what we see is that superiotemporal disc pallor can be noticed. BCV is 6/6 both eyes and N6 with plus 1.5 diopter spherical correction. Color vision is defective in the left eye, pupil is normal both eyes, and the lens is clear. So what we see here is that inferiorly, in the 30-2, there is an inferior altitudinal field defect. So can this be an AION, that is non-arteritic anti-ischemic optic neuropathy? The patient was also found to be taking tablets sildenafil, which is a phosphodiesterase 5 enzyme inhibitor, which is the risk factor for AION. This is a 120-degree visual field here. In the 30-2, it seems like only the inferior altitudinal field defect is present. However, when we see this, we can also appreciate the scotoma in the mid-peripheral, beyond the 30-degree in the superior arcuate region. So a depressed ERG response in both photopic and scotopic conditions. Sildenafil can result in AION, can also aggravate retinitis pigmentosa. It affects the phototransduction. Case number 370-year-old female, right eye 636, left eye 660. It seems like there is retinitis punctata albicans, sharp foveal reflex. However, when we look at the visual field, there is center involving scotoma. Conclusion, all three cases, the classical signs were not present. On top of that, confusing visual field defects and classical signs provided a diagnostic challenge. In the absence of typical signs, the diagnosis can be challenging, especially in low resource economy like ours, where genetic testing may not be easily available or feasible. So a full field suprathreshold visual field analysis covering 120 degrees superior over the standard 30-2 and hence should be part of the routine testing in suspected RP cases. These are my references. Thank you.
Nice, interesting cases. Dr. Jessica, you are a resident?
I'm a fellow in medical retina.
Fellow in medical. Okay. How do you diagnose retinitis pigmentosa? What is the criteria? If you want to diagnose, what is the diagnostic necessity?
Diagnostic necessity, if you talk about symptoms, the patient will present with night blindness. If you talk about clinical features, then the classical triad, there can be genetic testing, which is...
Is the classical triad must? So you mean
not
to say...
necessarily.
You mean to say a patient who has a normal fundus, and if he comes to you and says that my father or mother had a retinitis pigmentosa, please examine me, and patient is say 11 or 12-year-old, you're going to say that the patient, you know you don't have retinitis pigmentosa, you need not be worried?
Sir, we have to also do ERG testing, and we should take down the history of the patient. We have to have a pedigree charting, find out the kind of genetic inheritance pattern.
What is the diagnostic criteria?
ERG.
Is it ERG? So the diagnostic criteria for RP, what we read classical triad is in this end of spectrum. When the patient comes to you in the early spectrum, demonstrable dark adaptation, delay in dark adaptation is the first sign or a symptom which a patient can come up with. Everything else will be normal. Disc, vessels, no bony spicules, everything will be normal. So you have to demonstrate the delay in the dark adaptation. Okay, so that is the first earliest sign that can be. Of course, the definitive test will be the ERG, and then comes your clinical pictures. It is the disease process. Slowly, when there are different varieties of a gene.
Yes, sir.
In some varieties, there can be a full-blown picture at the age of 10, by the beginning of the second decade. But there are certain genes where you may not see the signs till the fourth or fifth decade. So RP has a varied appearances. Retinitis pigmentosa itself is a misnomer. Retinitis, it's not an inflammation. Essentially, it's a rod cone dystrophy.
Yes, sir.
Okay.
Yes,
so the classical triad is for an undergraduate to remember, as waxy pallor of the disc, the narrowing of the vessels, and bony spicules. But for a fellow like you, you should have done a good research on what is the diagnostic criteria for a rod cone dystrophy and how do we go about treating it.
Okay.
Anyways, very nice collection of cases.
Thank you so much, sir.
Like this, if the present. So the answer will be bony spicule is just a sign. It is not a diagnostic criteria or the diagnostic thing for an retinitis pigmentosa, the rod cone dystrophy. Many times, a spontaneously settled RD can bring up a pigment clumps like this. Post-inflammatory lesions where you have an exudative detachment, and when that dissolves, you can have the pigmentation like this. So multifocal choroiditis, a sectoral multifocal choroiditis can have scarring like this. So whenever you see scars like this, do not jump on the conclusion of retinitis pigmentosa. In fact, there is nothing like atypical retinitis pigmentosa. It's either a varied presentation of a rod cone dystrophy or it is not retinitis pigmentosa at all. So that was the term which was commonly used before, but now with the advent of many more diagnostic tests and clinical genetic evaluation and ERG which are available, the diagnosis is based on all these investigations and correlated with the patient's symptoms and the signs what you